all colleagues, teman-teman sekalian, dalam rangka meningkatkan kita menuju kepada status internasional, meningkatkan pergaulan kita ke pergaulan internasional, mendekatkan diri dari para surveyors, juga rumah sakit untuk bersiap-siap untuk tinggal landas untuk menuju kepada tingkat-tingkat yang lebih tinggi, tingkat-tingkat dunia, maka kita harus mulai dengan pergaulan internasional. Harus selalu berusaha menghadirkan pembicara-pembicara yang sangat utama di dalam bidangnya kepada teman-teman sekalian secara free of charge agar bisa meningkatkan semua ability ya. Jadi kemampuan kita mendengar dalam bahasa Inggris, nanti berbicara, bertanya dalam bahasa Inggris, jangan takut karena kita selalu akan mulai dengan tidak bagus ya. Untuk mencapai sesuatu yang bagus, kita pasti tidak bisa langsung bagus, tapi mesti kita mulai dengan yang tidak bagus dulu. Dan siapa yang lebih berani, biasanya dia akan lebih cepat untuk melewati masa-masa tanggung. Sebenarnya grammar kita Inggris sudah cukup di dalam sekolah, hanya kita tidak berani untuk mempraktekannya. Jadi Prof. Eugene Sinelson ini orang yang luar biasa, yang kita hadirkan luar biasa. I tell them that you are very famous in your field, very the first class professor in the United States. Bisa tolong diputar, kita mulai dengan doa dulu. Silakan Dr. Johnny.
Oke, terima kasih Dr. Hani. Teman-teman, Assalamualaikum warahmatullahi wabarakatuh. Selamat malam, good evening, Professor Eugene. We will start with a pray. I will lead the pray together. I'm sorry because we use Islamic method of praying. Yang terhormat Pak Sutoto dan manajemen KARS, mari kita berdoa bersama, dan teman-teman lain saya akan pimpin dengan cara Islam. Buat teman-teman yang selain Islam boleh menyesuaikan. Kita mulai. Bismillahirrahmanirrahim. Alhamdulillahirabbil alamin. Arrahmanirrahim. Maliki yaumiddin. Iyyaka na'budu wa iyyaka nasta'in. Ihdinas siratal mustaqim. Siratal ladzina an'amta 'alaihim ghairil maghdubi 'alaihim waladdallin. Amin. Allahumma shalli ala sayyidina Muhammad wa ala ali sayyidina Muhammad. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. Ya Allah, ya Tuhan kami, malam ini kami berkumpul kembali bersama dalam acara rutin kami KSK Knowledge Sharing Cars, yang alhamdulillah malam ini akan menghadirkan pembicara yang luar biasa, top dari negara Amerika, yang sudah kita tahu. Kami tahu bahwa kemampuan dalam public health-nya sudah lebih tinggi daripada Indonesia. Ya Allah, kami mohon berkah dan ridho-Mu untuk pertemuan kami ini. Lancarkan lisan kami, jernihkan hati kami, dan cerdaskan otak kami agar dapat menerima hal-hal positif yang akan disampaikan oleh Profesor Eugene Nelson. Ya Allah, berikan kekuatan kepada kami, organisasi KARS ini dapat selalu berjalan. Begitu juga rumah sakit di seluruh Indonesia tetap menjaga mutu dan keselamatan pasien. Ya Allah, tunjuki kami jalan yang lurus dan berikan kekuatan berada di jalan yang lurus. Serta tunjukkan pula jalan yang salah dan hindarkan kami dari jalan yang salah. Hanya kepadamu Allah kami memohon, karena Engkau adalah pengabul semua doa. Subhana rabbika rabbil izzati amma yasifun. Wassalamun ala mursalin walhamdulillahi rabbil alamin.
Amin. Terima kasih Dr. Johnny. Thank you Dr. Johnny for his prayer and nice word for Professor Eugene Nelson. The next session is the opening speech from Dr. Sutoto, please.
Good evening, Professor Eugene. Nice to meet you. As esteemed colleagues, healthcare professional, director of hospital all over Indonesia. It's both an honor and a privilege to welcome to you today. I'm especially excited for the insight we're about to gain from Professor Eugene from the Dartmouth Institute for Health Policy and Clinical Practice. Very distinguished figure in the realm of patient-centered care. Today, we delve into a topic that stands at the very heart of healthcare innovation and quality improvement using patient voice and prompt to improve patient experience, outcomes, and value. This subject is not just timely, it is pivotal as we stand at the crossroad at the healthcare transformation. Our guiding light must be the experiences, outcomes, and voices of those we serve. That's our patient. Patient-reported outcome measures, or PROMS, have emerged as a vital tool in our quest to understand and enhance the patient journey. These tools to do more than just measure outcome from a clinical perspective. They offer us a window into the patient's own perception of their health, quality of life, and the effectiveness of healthcare services. Integrating the patient voice into our care strategy is not merely an ethical imperative, it is a practical necessity. It enables us to tailor our services to meet the unique need of each patient, ensuring that care is not just delivered but felt, experienced, and valued. By listening to our patient, we learn not just about the symptom they endure, but about their hope, their fear, their expectation. This knowledge empowers us to provide care that is not only effective, but also compassionate and personalized. Professor Eugene's work in this field is nothing short of revolutionary through his research and advocacy. He has illuminated the path for healthcare providers to foster a more inclusive, responsive, and patient-focused healthcare environment. His insight on leveraging PROMS to enhance patient experience, outcome, and value are not just theoretical, they are practical, evidence-based strategies that have the power to transform the way we deliver care. As we proceed with today's webinar, I encourage each of you to listen with open mind and heart. Let us consider how we can apply these principles within our own institution and practices. How can we better incorporate patient voice and prompt into our decision-making processes? How can we ensure that our healthcare system are not just efficient, but empathetic and effective? In conclusion, I want to extend my deepest gratitude to Professor Eugene for sharing his expertise with us today. His dedication to improving healthcare through the integration of patient voice is truly inspiring. Together, let us this knowledge and use it to create a healthcare system that truly values and prioritizes the patient experience, outcome, and value. Thank you, and I look forward to an enriching and enlightening discussion. Thank you very much.
Thank you very much, Dr. Sutoto, our head executive. And now it's the time for Prof. Eugene. But before, let us see a little bit of his curriculum vitae, because it's too long, Professor, to put everything together. It will be 1 hour time. Please, curriculum vitae-nya dari Prof. Eugene. Yeah, thank you very much. Prof, it's your time. It's our time to listen. You are one of the best in the world. So please have your time.
Well, thank you so much for those wonderful opening remarks from your leaders.
Yes.
Deeply appreciate the wisdom and the commitment that I hear in your remarks, and it's an honor and privilege for me to be here with you. So thank you very much for this invitation. I'm delighted to be here. I'll see if I can share my screen and put up some slides that will help us on our discussion here.
Yes, it's okay. So
Okay, let me see if I can get the full screen effect here.
yeah, the full screen. Yes, that's it. Okay, it's
There
good.
we go. Okay. Well, my focus today will be on using the patient voice to improve health and quality and science. And as was mentioned, also the value of healthcare. We believe this is a way to make a triple play. In baseball in the United States, a triple play is a wonderful play. It's sort of like a hat trick in soccer. And we strive to make those triple plays. Let's see, trying to advance my screen. And see if this works here.
The arrow beside. Yeah, okay. That's the arrow. Yeah.
I can't.
Yeah, you can see it. Oh,
yeah, there we go. Okay. This is one of the most famous baseball players, Babe Ruth, in the 30s. He was both a pitcher and a home run hitter, and he hit many Grand Slam home runs. And our hypothesis here is that using the patient's voice can improve health outcomes and healthcare quality and health science, a triple play. The agenda is very straightforward. First, cases. Second, key mechanisms, how this works, what's underneath it. Third is the evidence of the impact of using the patient voice, and then a very brief conclusion. I like to start with real-world cases that will give you a sense of the whole of how the patient voice and PROMS, patient-reported outcome measures, and patient experience measures can make a big difference. So we'll have 4 cases that will go from a while back to today. The first case starts in 1998. Jim Weinstein on the right, Lisa Weiss, as well as a nurse, took a course on quality improvement that I was teaching, a master's degree course that I was teaching with Paul Batalden at Dartmouth in our Masters of Public Health program. And Jim's project was to design a spine center that provided one-stop shopping for any spine problem that you can imagine. And so he designed with his colleagues a spine center and launched the spine center in 1998. If you were to look at a diagram of how a patient worked in the spine center, you could use this diagram that a patient presents with their need, and right off there's an orientation to the center, as well as the collection of patient-reported outcome measures that leads to the initial workup and plan of care. And the plan of care could be anything from acute care management, functional restoration, to palliative care. And over here, we have a value compass. An individual starts with a disease status, a functional status, expectations for good care. And there's been on their journey, there are prior costs. And then they go through the system, and their journey starts with this new healthcare episode. And we can look at the change in disease status and functioning status, their satisfaction with the results, as well as the experience of care, and what the incremental costs are. And that can all be captured if you're careful with data that is both fed forward to help build a great care plan and to see how well it's working, as well as to provide feedback on how well that care worked for the patient and for different kinds of populations of patients served. So this is what it actually looked like. If I'm visiting the spine center, which I did, I'd complete a health status survey. It would take me about 15 minutes, and it included an entire review of systems as well as current health status. So that information that took me 15 minutes to enter is instantly analyzed and displayed like this initially. So on the left-hand side, there are risk factors, there's a history of the present back illness. There is the use of PROMS to look at functioning, and to look at symptoms, and to look at pain, and even the degree to which the care has led to symptom relief or more activities or sleeping better. So that this is a 15-minute health assessment instantly analyzed that becomes a basis for bringing the patient's voice and how they're doing and the clinician's voice together, as well as in this case, you can see the history. This approach was then adopted by 10 other centers around the country. Those 10 spine centers around the country worked together to do a randomized controlled trial for people who were candidates for back surgery or for not getting back surgery. So it was a randomized trial, and there were two good choices as far as the evidence showed. I can, as a patient, have back surgery, or I can be treated without back surgery and treated with rehab and medical means. This was done in 12 centers, led to over 100 publications. So you can see that this feedback of patient-reported outcome measures, along with other things, actually contribute a great deal to science. This is a value compass. This is one way of summarizing the study's results after 2 years for people presenting with a herniated disc. So in blue, we see the results for people randomized to surgery, and in yellow, people's results if they were randomized to non-surgical care. If we look at clinical outcomes, such as symptoms, you can see that the surgical group did better. Both improved after 2 years, but the surgical group did better. With respect to physical function, again, the surgical group did better. Both groups improved. The surgical group improved more. If we look at the satisfaction with their health results, how much their treatment had helped them, we again see this result favoring surgery. But if we look at the total costs of care, we see that the total costs were higher for surgery. So it cost more than non-surgery and got better results. Now that those results for the entire set of patients can then be turned into predictive medicine, and was. So that now, if after this trial was done, if I went to the spine center, I could get personalized predictive medicine. And remember, this is back more than a decade ago, that I could go to the spine center And I could see the results of if I opted for surgery versus non-surgery based on my characteristics and a prediction of outcomes. So that's, I think, a very interesting and important early example of using patient-reported outcome measures to improve the individual patient's outcomes, to look at the quality of care, to improve science, and also to pay attention to value. Now, in 1998 or thereabouts, my friend from Sweden, Stefan Lindblad, was visiting Dartmouth. And he was going to spend a week with us. And he was in my office in the morning, and we were talking about his rheumatology register, rheumatoid arthritis register, that covered everyone in Sweden. He was a MD, PhD. He had worked with all of the rheumatologists across Sweden to develop a register that would track patient characteristics, treatments, and outcomes for rheumatoid arthritis, RA patients. And I said, well, that is wonderful, of course, very important. But why don't you spend this afternoon at the Spine Center and see what they're doing with their system that does include a registry. So the next morning, Stefan, Dr. Lindblad, was back in my office, and he said, you know, Gene, we could do this in Sweden. We could do what they're doing in the Spine Center in Sweden for our rheumatology patients. And they did it. So what they did, it took a few years to get this all rolling and up and running in the way that they wanted to. But this is the Swedish Rheumatology Quality Register approach, which started in 2002 and is still being used today. And this is a patient registering her data on swollen and tender joints on a tablet. This is the patient's self-management tracking data that the patient uses to see how they're doing with respects to their disease activity or their symptom burden. This is the clinician view that shows the same patient with their clinical outcomes over time, laboratory values showing disease activity, and alongside the patient-reported outcomes over time against the medications prescribed for rheumatoid arthritis that were being taken. So that's the clinician's view. And you won't be surprised when they get together, they had a dashboard that summarized over time the visits that this person has made to their rheumatologist. And of course, this is in Swedish and very small. But what you're seeing here are patient-reported outcome measures and clinical measures and medications. So patient-reported measures over time, patient-reported measures over time, clinical measures over time, medications over time. And this individual, it's color-coded, in September of 2015, started to have a worsening disease state. They went into a flare-up in November and December. That's the red coding. And then you can see that in January, getting better, and in remission by February, and that remission continued on. Well, what happened? This was a person where the medication that they had been taking, the Remacan, had been wearing off. And so they were switched to another biologic or a combi, and that created the improvement in symptoms. So this system that involves patient self-care, monitoring their PROMS, alongside clinical care, was associated with a dramatic decrease in disease burden for RA patients all across Sweden. So in red, you're seeing from 2004 to 2014, a decrease in flare-ups from RA from 11% down to about 4%, make that 5% across all of Sweden. So more than cut in half the flare-up rate across Sweden. The blue line you can see is quite wildly varying in terms of remission rates. And then look at what happens. All of a sudden, gosh, in 2009, that blue line is much less variable and often is better than the rest of the country. You know, what on earth happened? And what happened was a new leader came to Gävle County. A new clinical chief was took over, and he said, you know, let's use that registry data like Dr. Lindblad has been using it in his clinic, and like he's asked us to do. Rather than just using it as a registry and for research, let's use it with the patient, just like we've been asked to do. And when they did that, you can see the dramatic change that took place when they engaged the patient in using their patient-reported outcomes for self-management in between visits. That's what happened. So now we're going to go to a more recent case, and this is on inflammatory bowel disease. Inflammatory bowel disease, a serious condition, of course. And it's a national quality improvement program that started in 2015. I was having breakfast at a local restaurant, Lou's, with the director of the network, the Chorus National Quality Improvement Network. And he and a buddy from California, Cedars-Sinai, Gil Melmed, had started a improvement network with about 10 IBD centers. And they were trying to get it off the ground, and we had breakfast at Lou's, and I told them about the kinds of things that I've just shown you, the value of building a registry that's based on feeding forward patient-reported outcomes, collecting clinical outcomes and patient data along with the patient-reported outcomes, creating a registry and actually using it in these novel ways. So this is Corey Siegel. This is actually a IBD patient that actually worked with us for a couple of years. And this is an image of the network that is now national and includes over 50 centers treating people with inflammatory bowel disease. So you can see that the centers are spread across the United States. As I indicated, it started in 2015 with about 10 centers. And what we were talking about at the restaurant Lou's at breakfast was what we call a learning health system for co-producing better health outcomes and better patient care experience and value and science. And I'm going to explain more about this later. But what they did was all of the practices participating started to really focus on this, the patient-clinician relationship and the care plan that comes out of that, and fed by patient-generated data and clinical data to create a better platform for making assessments and treatment plans together for the betterment of that individual person, in this case, suffering from IBD. And they formed a registry, and they formed a quality improvement network to improve health and value and research. This is a image of the feed forward patient-reported information that is collected before every visit that an IBD patient makes to these 50 clinical programs serving IBD patients. It actually starts with the patient's actual voice, asking them what is their number one concern or goal related to their IBD. And they actually write down their number one concern or goal here. And then we have information on symptoms. And down here, we have information on outcomes like ED visits or hospital stays, as well as two key facts. Is the person on prednisone or a steroid? Are they on an opioid medication? So this takes the patient about 5 to 10 minutes to complete. It's instantly analyzed and then shared with the patient. So this has been collected since 2015. Currently, the 50 practices are focusing on whether or not the person is having flare-ups. And this will show you what happened from 2018 to 2020 when the group focused on their IBD patients and avoiding flare-ups. And one outcome measure that was featured, primary focus, was emergency department utilization. So there was a before period where they were just tracking outcomes. And you can see it was running up that ED visits across all of the practices at that time, about 35 practices, was averaging about 13, 14, 15%. With some variation. And when they started the program to improve and standardize the approach to treating their patients, you can see that there was a shift, and the rate of ED utilization dropped substantially across all of the 35 practices, and that covered 24,343 patients. This is the patient-facing symptom management dashboard that is now under development. It's being used by some patients in some places. You can see that the patient is tracking outcomes over time through self-recording. And in this case, we're looking at just a couple of symptomatic outcomes. And down here, we're looking at office visits and changes in medications. And so this self-management dashboard is now being perfected, and you'll see that it's quite similar in overall function to what the Swedish Rheumatology Quality Register has been doing. So some key lessons learned, very practical, 3 lessons. Find a simple, standardized way to capture a small number of patient-reported measures that are important to patients and clinicians. Share this data with patients and the care teams as quickly and often as possible. Create spaces for patients and care teams to discuss and reflect on this data to turn it into action. So one last case, we're in present time, and this program is called About Me. using the patient's voice on what matters to improve outcomes in rural North Carolina. Rural North Carolina, this part of the United States, about 60% of the population, 50 to 60% of the population are Black, people of color. The rate of poverty is very high, approximately 35 to 40% of the families are at the poverty level. Very rural, with two very progressive hospitals that hired a friend of mine, Greg Kotzbauer, to work with them to improve the quality and value of care. Two hospitals hired a friend, a graduate of our program at Dartmouth, to work with them. And the first thing that he started, one of the first things they started, was this program that is described briefly next. About Me, the care principles focus on the person, not just the disease. Allow patients to tell us what matters to you versus what is the matter with you, what matters to you. And for this population, bringing together health and social care providers and health and social care resources across the communities is essential to deliver better care and to get best outcomes. So as I mentioned, this was a very rural area. At that time that the program started 3 years ago, it started as simply as handing an index card that looked like this to every person visiting initially 4 different primary care practices. Now it covers 50 primary care practices 3 years later. But then it was, when it started, just 3 primary care practices and an index card. The front of the card said, what are your goals for the visit today? You'll see that lesson learned from our friend Greg Kotzbauer. Actually, he had been at Silicon Valley before coming to Dartmouth to get his master's degree. So he was a high-tech guy. He started with an index card. Next question is, within the past 12 months, I've been concerned about the following: my health, feeling sick, my unsafe living area or unstable housing, my medications, feeling lonely and isolated. So people would tick off their answers to that question. Are any of your needs urgent? And then they'd flip the card over, and there were just a couple more questions. I am very confident or not very confident or somewhat confident that I can take care of most of my health problems. So is that person capable? Do they believe they're capable of handling their health problems? Would you be surprised if you were admitted to the hospital or visited the emergency department in the next 30 days? Unsure, no, I would not be surprised. Yes, I would be surprised. And then the best way I learn. And then they were invited to draw a picture of something that they like or they would want. That index card, completed in the waiting room, was then handed to the doctor that saw them, and that started the visit. So again, feeding forward the patient voice and some brief information on them to front end load the visit. This is a patient story, William, and a person that the primary care practice thought was so challenging that they needed extra help could be referred to one of 2 people that were high school graduates and had been trained to be community health workers. So William was asked to visit a community health worker, high school graduate, people that looked like them that had been trained to help people like William. So they started out by focusing on trust, building trust, and they worked over time to build William's sense of self-efficacy, ability to take care of myself. And he was unemployed William now has a job, 28-year-old person with diabetes. He had health education. He had a car. He had been unemployed. Now, as you see, he has a job. He was uninsured. He had no primary care physician initially. He had 2 children, was divorced, and catch this, 17 inpatient or outpatient events, so hospitalizations or ED visits in the past 18 months, all medical, all was discharged from home. So after the community health worker had spent 5 hours with William over a 4-month period, William had no admissions or no ED visits. So that was clearly a success story. Clinicians' view of the program, having the referrals to the community health workers, very helpful. I think this card is fantastic. As a physician, I'm missing this information. Financially, it's a win-win for the organization. The data optimizes whole person care. This is the type of innovative work that will put our hospital on the map. Patients, a few of their voices. This program y'all have is awesome. I wish everyone did this. I love how I have someone to call with all kinds of different questions. I've never had anyone care for my health and needs like this before in my life. Thank you for listening to me and caring. Finally, there's one service to help get the care me and my son actually need. And as mentioned, there was a very positive financial impact. Medicaid patients, those are low-income people with government health insurance, 51% drop in inpatient utilization, and self-pay patients, 22% drop in inpatient utilization. This is an image of their whole person care model that they think they are building towards, starting with the primary care teams and then partnering with community resources and pharmacists, et cetera, to create a healthier community health system that helps individual people, whole person care. Optimal outcomes, lowest cost, and there's a toolbox to help practices get started. Interestingly, this program is now being tested in a low and middle income, a low income country in a very small way. So we're more than halfway through this presentation. We're going to get in a bit deeper. So part 2, using patient voice as a key mechanism for capturing what matters most to the person and how they are doing, and to building a care plan that is actually effective and meets their needs. 2 key mechanisms that I'll talk about briefly. One is the learning health system, and the second is co-production. So 2 key mechanisms. Before focusing on those 2 key mechanisms, let me just say a word about patient voice. They come in many flavors. You've seen me in these cases talk about the patient's goals and concerns. We believe that actually starting in their own words with goals and concerns for agenda setting and relationship building and care planning is actually the best way to start. It's very easy to do, but it's not done very much because doctors aren't trained to use that kind of a question, and also to give the person time to think about before they actually see the doctor. So that's very helpful to do this before the patient sees their doctor. Outcomes, patient reports on health status changes over time, patient-reported outcome measures, PROMS. The patient experience, patient reports on the experience of care, PREMS for short. And then you've heard me talk a little bit about, at the end of the day, what's the person's belief about how much they have been helped, their perception, their view, their opinion of how much they have benefited. Patient concerns, outcome measures, personalized outcome measures. So those PROMS and PREMS come in different shades and colors. Now, learning health system is becoming a popular term around the world. It's a relatively new term. It was actually popularized by the Institute of Medicine that's based in the United States. The aim is best care at lower cost for a learning health system. And here's the formal definition: a system in which science, informatics, incentives, and culture are aligned for continuous improvement and innovation, with best practices, the evidence-based best practices, seamlessly embedded in the care process, patients and families as active participants in all elements, and new knowledge is captured as an integral byproduct of the care experience. So I like to think of it as a two-part system that every person can benefit from the best available evidence applied to them, and every person's care experience, treatments, and so it's double loop system and double loop learning. A learning health system for outcomes, quality, science, and esprit de corps. This is a framework, a picture of the model that we use. I mentioned this earlier. It starts really here with a sharp focus on the patient and the clinician coming together. And that coming together builds a relationship which is powered up in part by feeding forward the patient's data alongside and using it alongside the clinical data. Better conversations, better decisions, better relationships leading to better outcomes. So we've created a shared information environment that can be used for three additional purposes. One is a patient and family-facing support network. More on that in a bit. Second is a care and quality improvement network, such as you saw in the Swedish rheumatology quality case, and in the inflammatory bowel disease case, and in the spine case. They had formed an improvement network. And underneath it all is the registry. And the registry is a byproduct of the data collected at the point of care, just drops into the registry. No retrospective medical record review, drops into the registry. And that information is used back at the individual patient level, is used by the improvement network that is clinician facing and care team facing, as well as the patient and family network that is patient and family facing. So a little bit more about the patient and family network. It's peer-to-peer support. It's often done virtually. It can be face-to-face. In addition to peer-to-peer support, one person helping another person like them, but might have more experience because they've had the disease or condition longer. In addition to that, there's navigation and information about resources that can help you. And oftentimes information on best available evidence. So this patient and family support network is evidence relevant to you, local resources, as well as peer-to-peer support. All of that aims to develop the best health, the best care value, the best quality, the best research and science. And this kind of a system adds a lot of esprit de corps and good feeling about how my work is going and what my work is doing. So there's a real benefit to the care team as well. The core of the model is this: there are 2 patients in the room, and we say it starts here with co-assessment of the person's current health status, co-decision, this is shared decision-making about taking into account the evidence and my values and preferences. What should my care plan look like next? Now that we know the basic care plan, how do we design it so it actually works here and now for us and me? And how do we deliver that? So it's assess, decide, design the care plan, deliver this cycle, very common cycle. And these are the points that I just mentioned. 2 experts in the room. That's the core of the model. So this learning health system approach for producing better health, value, science, and esprit de corps for professional staff is being used in a lot of places globally and in our country and in our region and in our health system, the Dartmouth Health System. These are some of the different conditions that have been mentioned or that we're currently working with or working on. This last one for serious illness is a Dartmouth Health System strategic program to become a total learning health system for all the different patient populations that we serve, starting with serious illness such as cancer, and now moving to all kinds of people. These are a couple of papers that explain this in more detail. This was in the BMJ in 2016, and another paper, co-production, in 2020 that describes in more detail what I've just been covering. This idea of co-production. Co-production is a relatively new term. For many of us, it's not brand new. Eleanor Ostrom in 1998 won the Nobel Prize for her work on how using co-production by bringing service providers and service users together is actually a more efficient economic model than a competitive model. So she used the term co-production to describe a system of providing services that require cooperation, such as sewage systems, such as how do we protect our common pastures or our common fisheries or our water supplies, et cetera. So she really put this term on the map. People like Dr. Paul Batalden and other people around the world learned from Eleanor Ostrom's work and said this is actually fundamental to healthcare, isn't it? Because all services at some level are co-produced. Other than the time I'm undergoing surgery, as an example, the services, I live with my healthcare, my health 24/7, 365, because of the nature of healthcare. It, by definition and by function, is co-produced. So here's a formal definition: the interdependent work of patients and professionals to design, deliver, assess, and improve the relationships and actions that contribute to the health of individuals and populations through mutual respect and partnership that leverages each participant's unique assets, expertise, and actions. So a formal definition. And this is catching on. One of the most prestigious journal in the scientific world, one of the top two, is Nature. Nature had a special issue on co-production as being power to the people. Co-production is better for society. It also leads to better research. So it applies to economics. It applies to us in healthcare. It applies to the scientific community. So we're almost done. I'm going to provide 5 proof cases that show the impact on outcomes and quality. This is something that I used earlier, Swedish Rheumatology Quality Register remission rates. This is a little bit fancier layout and goes from 2002 to 2017. So here we see that we're at about 12.6% in 2002 to 2005. Now we're below 3%, a 5-fold decrease. RA remissions reduced by 75% across all of Sweden. Remarkable. We've worked a lot with cystic fibrosis and the cystic fibrosis network across the United States. We've been working with them for about 15 years. And they've taken on this learning health system approach. And everything they've done along with the learning health system co-production approach has actually led to a gain in life expectancy before biologics became available, a 12-year gain in life expectancy before 2000 up to 2012, from 2002 to 2012. Huge gains by using these methods without any breakthroughs in medications. This is pediatric inflammatory bowel disease. I mentioned before adult, and you saw the impressive results there. Well, the same thing is happening in pediatric IBD. Another set of colleagues have started a program that is now national, based at Cincinnati Children's Hospital, now national. And from 2007, with about 15 sites, they started the Collaborative Improvement Learning Health System Network at about 40% prednisone-free remission. By 2018, they were at 80% prednisone-free remission. This improvement has continued. Finally, a relatively new player on the block. This is multiple sclerosis, a colleague based here at Dartmouth who actually leads our patient experience program for Dartmouth Health and the provider experience program. Went from about 11% flare-up rate or relapse rate. And you can see a very dramatic shift here. This was 4 centers using this collaborative improvement approach down to under 5%. Relatively rapid improvement from July 2017 to December 2019. This program is now being expanded. Finally, last case, proof case, this is people with breast cancer. And this was done by Ethan Bash in a New York City hospital that was treating metastatic cancer patients. All that was done was patient self-monitoring to record their symptoms, and once every 2 weeks, make a call, send their symptom result monitoring to the nurse at the medical center. So the symptom monitoring group versus the usual care group in one large program, you can see the percent surviving at 8 years favored PROMS. This is now a national trial being done. Dartmouth is one of 10 programs taking part in this. So simple symptom monitoring amongst women with breast cancer in a randomized controlled trial led to lower mortality rates. So final slide, conclusion. This is the hypothesis once again, and we believe that using patient's voice can improve outcomes, quality, science, value, and health professionals' pride and joy in work. So thank you for allowing me to talk with you, and looking forward to questions and discussion.
Thank you, Prof. Eugene. You finished?
Yes, I am. I'm trying to get my pointer to stop the screen share. There we go. Sorry, it took me a while to find that.
Oh, no. You very superb. Dear colleagues, we have an enormous time with Professor Eugene, who is the best professors about co-production and PROM and PREM, and I'm a little not yet. I don't know about the PROM and the PLC. With what was the other one? The fourth one, Professor?
PCOMS. Person-centered person-centered outcome measures, personalized.
Personalized
Yes.
centered outcome, yang personalized. Jadi semua dijelaskan dengan sangat rinci dan hati-hati, dan sangat jelas. Jadi co-production itu kerjasama antara petugas kesehatan atau dua pihak yang memberikan hasil dan yang menerima hasil, dan sebenarnya kita juga laku. Itu silakan Prof. Dr. Niko Lumenta.
Baik. Terima kasih. Kedengaran suara saya?
Kedengaran. Tolong di pin. Ya, oke.
Prof. Eugene Nelson, thank you very much for your very comprehensive lecture. I would like to ask you two questions, but before that, we are concerned that the PCC, patient-centered care, CARS is bringing it to the hospitals, especially, and to the healthcare professional. And then we try to explain the patient engagement. And then next, the semantics is patient experience is a quality indicator, patient voice, as you mentioned, and then PROM, also PREM, patient-reported experience measure, and one
personalized
terminology is patient-centered outcome measure, and then co-production. All of these semantics terms for a beginner journey to the PCC makes it difficult to understand, but the lecture is very comprehensive. Now, you mentioned about the patient conditions, rheumatology, arthritis, inflammatory bowel disease, etc. It's a chronic condition. So I get that this PROM is better for patient communities and chronic condition. Yeah. First is that. The second question is, I think the community patient must have enough health literacy so we can ask them to join engagement and empowerment. So the latest one is we CARS try to push for good governance. One is good hospital or corporate governance. The second one is good clinical governance. It started from England. And then good patient care, the third one. And the fourth one is the good ethical governance. That is Professor Eugene. Thank you.
Well, thank you for those comments.
Prof. Eugene, maybe I will introduce Dr. Nico. Is the one who started patient safety in Indonesia in 1995. So we call him the patient safety professor in Indonesia.
Wonderful, wonderful.
I'm a nephrologist daily clinics. Yeah.
Yes. Well, I think the points that you make about the terms that I used, a lot of new words I did use, and I hope I was able to explain them in a way that could make them understood. I think that is one of the problems that we have in healthcare is our terminology, and so I think we suffer from that, and my presentation suffers from that as well.
Sorry. So you use learning health system?
Yes.
Yeah, for take over the suffering.
Yes. The last point you made many great points, but on health literacy, couldn't agree more that the people that are most health literate are most likely to benefit first from the kinds of things I was talking about. Those that are least health literate are least likely to benefit. So that's always a big challenge to be teed up first, so that you start to, if you will, co-design the new program with all kinds of people, so that both the health literate and the health non-literate are involved in the initial design, the initial testing, the initial implementation, the initial evaluation of the initial implementation, so that you can adapt it so it works for everyone. And I think that's point one, is the co-design by patients from high to low literacy is a fundamentally good way of designing early testing, initial implementation. The second is that the peer-to-peer network that is part of this framework, in part, is meant to boost health literacy peer-to-peer, so that you can be talking with, either in person or with your phone or with your computer, people that have the same condition but know how to handle it better. And they are high in health literacy, but they aren't necessarily so different from you, so that you can learn from your peers about what the best treatments are, what you need to do for yourself, what you need to ask the doctors and nurses to do, et cetera. So I think that part of this model, peer-to-peer, is one way of boosting health literacy and attending to that, as well as taking it into account in the design from start to finish.
Yes, thank you very much. Professor Eugene, there's 3 questions here coming for you. The first one is from Dike Afifi. Bismillah, this presentation is awesome, Professor. It gives us a lot of inspiration. How can we get income as a hospital from this patient center monitoring method, how can we get income? Could it produce some wealth to the hospital, something?
Yes, there's, I think of this as smelling the coffee. That there are two accounting books here. And one is the accounting books for the family and the government that might provide insurance that stands behind the family. And the other is the provider. It's the hospital. It's the clinician. And so my expense as a patient is my doctor's income. My expense as a patient when I visit the ED is my hospital's income. And so that's smelling the coffee. And we have to understand what you're saying here, that I like to think about it really with these two viewpoints, with these two lenses. So for example, right now, we're starting a program in primary care in rural Idaho, the far west. And it's 10 clinics that treat low-income patients and especially disadvantaged patients. And we're starting a program like I was describing, feeding forward the patient voice to match health and social needs with care plan. And we're actually doing an evaluation with both books. What does this do in terms of, from the insurance company's point of view, are they keeping more money or losing more money on those patients, including the federal government, the Medicaid program for poor people, versus the primary care clinic books? The more they see the patient, the more income they get. So fewer visits to them and means less income for them.
Yes.
And we're also looking at the hospital books so that we're looking at both sides of that
advantages
issue to do an evaluation of the impact, to be fair-minded about it. When you go to the mission of the hospital, they'll say, sure, we're with you. When you go to the CFO, they'll say, no, look at my books.
Yes. And if you train the people, not on clinics, do the primary, the Medicaid will pay for the effort? No, of course, yeah.
For education.
For the education.
No.
Because it's talking together, need time.
Yeah, there's no special payment for this, but
social work.
well, let me take that back. For most patients, there's currently no special payment.
Yeah.
Some insurance plans, a few, do provide payment, and the direction over the next 10 years that these kinds of services will be paid for. Now, it's rare, but there are prepaid health systems that do pay for this right now.
Yeah, I understand. It's more social work, yeah. And
yes.
Income. And then from Dr. Juniwati Gunawan, can we get your PowerPoint, Professor?
Presentation.
Your
presentation.
Your
yes,
presentation.
I'd be happy to. Yes, I'd be happy to send that to you, of course.
Okay.
Yes.
Thank you.
Yeah, maybe you can send it in the chat box, and then send it, because some will maybe translate it and learn it a little bit slower, so they can get what you're talking about, because some are already good in English, some are
We will do that. We will do that. After you
Yeah, it's
send
very
us,
good.
we'll do that for
Okay.
the.
Thank you, Professor. And then
Admin.
from Dr. Sahat Sihaan, I want to ask Professor Eugene how we know that PROMS can answer the quality of life of patient.
Right. PROMS and quality of life. When I think of PROMS, I actually started, this is going back historically, we started our first effort to look at PROMS in 1988. And no, I'm sorry, 1978. We published a paper in about 1980 in JAMA, and the we is a network of primary care practices, 10 primary care practices in our region that had formed a research and improvement network. The first project was on blood pressure control. The second project was to look at the functioning and quality of life of primary care patients. At that time, there were no measures of functioning and quality of life for patients.
Yes.
Everyone knew, not everyone, people had come to believe that paying attention to activities of daily living and functioning was really important. There were no measures. So our primary care cooperative, it was called the Dartmouth Primary Care Co-op Project, over a year period, designed, tested, and evaluated 8 measures, and physical function, mental health, social function,
Yes.
overall quality of life, social isolation, pain. We had 8 measures that could literally be made a chart on the wall. So one chart might be pain, the next one might be physical health, the next one, rate yourself, the next one might be overall quality of life. So as we initially conceptualized patient-reported outcome measures in 1978, working with primary care physicians and patients, overall quality of life was in there, as well as social isolation, because we knew it contributed to health and quality of life. So we've always considered, if you look at maybe the world's best set of patient-reported outcome measures that is general or can be disease-specific, it's called PROMIS. They're now translated into over 15 different languages. And PROMIS includes physical health, mental health, social and role function, quality of life, symptoms, etc. So we've, from the beginning and to current state of the art, include overall quality of life as part of patient-reported outcomes when you're doing a full health assessment.
Yes, thank you. Ada yang resen, tolong di
Ada itu Pak Chandra.
Ya, Pak Chandra, tolong dimasukkan.
Okay.
Ya, terima kasih Pak Chandra. Thank you, Pak Chandra. You can cast.
Thank you for your wonderful presentation. My name is Chandra Apriyadi, and I am a nurse. I'm working in a general hospital in Kupang, NTT. Implementing the use of patient reports outcome measure and incorporating patient voice to improve healthcare experience, outcome, and value. Based on your explanation, in my understanding, it needs health literacy, quality, and reliability of data, stakeholder engagement, and also is affected by cultural sensitivity. To discuss with, what is your advice to start using PROMS in order to improve healthcare experience and outcomes of care in a hospital setting in low resources areas such as my place? Thank you.
Chandra is staying in the east part of Indonesia.
Yes.
Very beautiful, but there are
Yes.
more lower economic power.
Right. A great question. I appreciate that, Chandra, your question. To get started, I think the last case that I used, the friend Greg Kotzbauer working in rural North Carolina. What he did there was first he got the leaders and policymakers of the hospital to be interested in improving outcomes for everybody, and then help them to understand that starting with patient voice was one of those things. So starting with leadership and trying to make to get them to be on board and supportive, if not enthusiastic. Then coming down a level, it always, in my experience, starts with finding some clinical champions, some clinicians who are, they'll raise their hand and say, I think this idea is a good one, and I'd be willing to help you, Chandra, start testing this, using it with my patients. So finding a credible clinical champion or champions that are on the ground, that are great clinicians, that other clinicians respect and share your values that you're trying to put forward is number two. Really good clinical champion. The next is this idea of starting simple and to start like with paper and pencil, not with the EHR, if you have an EHR, but start with simple methods of collecting a small set of patient-reported outcome data that is, here's the next thing, is co-designed by, I think of it as a lead team. So the lead team might be, this may or may not be possible in your setting, but a lead team might be the clinical champion, physician and or nurse. Ideally in your setting, hospital, clinical champion nurse, clinical champion MD, a specific patient population, let's say a ward, a unit, one of many wards or units that's serving a particular clinical population. And then co-designing the startup with some of the principles that were mentioned earlier. Start simple, start focused, just a few measures. Make sure the measures are important to both the clinicians and the patients. So they're important to professionals, they're important to patients. And so the co-design team, let me go back to that, would include the people, the professional roles, RN, MD, might be medical assistants, might be inpatient unit charge nurse. It might be in our world, we used to call them orderlies. So one of each, it's a little bit like Noah's Ark, one of each type of health professional that works in that unit becomes the lead design team along with a couple of patients to get the patient voice on the design team. Actually meeting with you once a week or once every 2 weeks or once a month to get this planned and started on a small basis. So then it's classic improvement. Plan, do, study, act. Let's start with these first 5 patients that come in next, and let's give them a brief questionnaire, health assessment. Maybe it's 5 questions. And if they can complete it themselves, they do. If they can't complete it themselves, maybe a family member can work with them to complete it. Step 3, if that doesn't work, ask a nursing assistant to complete that by interviewing the patient. So now we have the results that have been co-designed for our first 5 or 10 patients. And we look at that and say, can we fit this into the workflow? Can we use it the way we hope to use it? How should we use this? And another thing that you'll note is I think it's always a good idea. We didn't say this 10 years ago. It's always a good idea to start with the person's own words about their current goals and concerns. And people are especially good at what their worries and concerns are. I know what I don't like better than I know what I like. So, really asking about, geez, what are your worries and concerns right now about your health? What are your goals? And just getting that off, top of the head, word of mouth is really a good place to start, because you're starting with where they're coming from. So those are some of the basic steps in getting started that I would think about. I didn't show it, but in the slide set, one of the last slides is about 10 steps to get started. So when you look at the slide set, you'll see 10 steps literally to get started that mentions these kinds of ideas.
Thank you very
Really
much.
get it. Thank you.
Yeah, it's very, 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 very. Now our boss will going to ask Dr. Sutanto. Please put him. Tolong dipin Indra, Pak Sutanto. Silakan Pak.
Professor Eugene, thank you for your excellent presentation, which is very valuable for us. Yeah. I would like to tell you that CARS with Dr. Hani and Dr. Nika have just initiated the establishments of the Indonesian Patient Center Care Institute, which aim to educate health services in Indonesia about various aspects of patient-centered care. About patient-reported outcome measure, I think that PROMS are an important component in effort to make healthcare more patient-centered, improve quality of care, and strengthen health outcome. The question is how to integrate direct feedback from patient so that healthcare provider can better understand and meet their need, leading to better care, more effective, and higher patient satisfaction. Thank you.
Right. How to build it in so it really works for the clinician. My sense of this is, as I just mentioned, to really pay attention to this in the co-design. The goal is to fit it into workflows, number one. And the second goal is, let's say, to have the clinician say, oh, this helps me do my job better. In fact, I save time because of what I learn from this information. I know more quickly what this person needs. So that's the goal. In an outpatient setting, so for example, when we started using the patient voice in the first 5 cystic fibrosis practices, I was interviewing one of the first physician champions that was using it in a small practice and treating CF, cystic fibrosis patients. And he said, you know, just before I put my hand on the doorknob to go into the patient's room, I look at that sheet, and I see where that person's coming from and actually how they're doing, and it level sets me. I'm ready to have the conversation because I'm in their zone. And so before I put my hand on the doorknob, I look at that sheet that shows their voice and their clinical status from patient-reported outcomes, in this case, alongside clinical outcomes. And now I'm really prepared for the visit. So my visit is better. It's more person-centered. It's more clinically relevant. Takes less time to have a good visit. So I think that's a key. Another physician in the, I mentioned his name in the inflammatory bowel disease case, Corey Siegel. When we were doing that 10-person pretest in Corey's practice at Dartmouth, he said, we were having breakfast at Lou's. And he said, Gene, this is great. You know, every visit is a 15-minute sprint. I've got 15 minutes to see my inflammatory bowel disease patients. It's a sprint every 15 minutes for all the morning and for all the afternoon, except when I'm doing procedures. This gives me a head start. This gives me a head start for my visit. So he was saying the same thing that we had heard 5 years earlier from the doctor treating people with cystic fibrosis. It actually helps me have a better relationship, make a better assessment, do my job better, develop a care plan that's more likely to work. Done. So, you know, double win. That's what, you know, that's what you're striving for. Not necessarily easy to accomplish, but can be accomplished, and that's the goal.
Yeah, super, Prof.
Thank you.
Can I ask one small question? Do you have to redesign the recorded the questions, or once you made it and it's final?
Within a setting or across settings?
Yeah, just the card. You have questions.
Yep.
Did you say something you need to take out some questions, or just to put another question, new question, something like that?
Yeah, as you go from, let's say, place to place, and population to population,
Can be what's changed.
Yeah, you step back and you say, it's again co-design. Now, our setting is this. It's this place in.
It's final.
It's this hospital or it's this clinic. And if I want to look at the patient reported information, what from this card really makes sense and would be valuable to me? What's missing that I should add? What's not relevant that I should take out? You could do the same thing with that questionnaire that I showed for inflammatory bowel disease. You know, it's generic, but it's customized to inflammatory bowel disease. So the general categories are right. The individual items might not be right.
Yeah, not right. Okay, thank you.
Terus sesuai pertanyaan Pak Niko, Han. Dr. Pak Niko ada questionnaire.
We have some questions more. This is from Wajib Muslim Sunarko. He said, what about a patient who talk too much?
Right. A patient that talks too much. Yes, my sense of that is actually pretty simple. That there are probably, let's say, senior clinicians in your setting or that are in your circle that are good at managing how much the patient talks when the patient tends to talk too much.
Yeah.
And, perhaps getting coaching from a really good peer that knows how to have a good conversation in the limited amount of time might be one simple approach, coaching.
Approach. Yes.
Yeah, if
Thank
it's
you very
possible
much.
to observe that clinician that's having that real problem, have somebody observe, maybe videotape, and then having the clinician that's really good at handling communication, look at the videotape. They could look at it together
Yeah.
and have some coaching. Low cost, very effective method.
Yeah. I think it's very nice to Pak Muslim. Jadi untuk direkam dulu, nanti dokternya nanti bisa lihat pelan-pelan. Yeah, this is one more question from Dr. Nico. Is there a general questionnaire for the PROM?
Yes.
Standard questionnaires.
There are many standard questionnaires, and many of them are very good. Some of the standard questionnaires, literally, there's probably hundreds, frankly, but they fall into two categories.
Okay.
General, apply to anyone. Condition specific applies to people with condition X. So one decision is depending on where you work and the kinds of patients you treat, do you want to take a validated questionnaire and use it or customize it that's general or disease specific? And they're out there and usable for many populations. Then second, I mentioned this earlier, it's called PROMIS, PROMIS. There's a PROMIS set of questions that National Institutes of Health funded for 15 years to develop patient-reported outcome measures for symptoms, physical function, mental health, social function, quality of life. And you can actually go into the question data bank and pull out questionnaires or items that have been validated and are standard. Some are symptom specific. Most are general. So there's a wonderful resource from PROMIS. Another organization called ICHOM, ICHOM, has developed validated questionnaires for specific populations. So if you have the ability to do a library search on validated measures for this population, you can find a lot of validated questionnaires for most populations.
Superb. Tolong Dr. Nico dimasukkan lagi.
Okay. Professor Eugene, I want to show one slide, journey of the KCC. Okay. I make it bigger one.
Right.
Okay. This is a journey, important events from Picker up to ISQA, person-centered white paper. The three mental model you mentioned about what is the matter, what matters me of the patient. So I noted important event to this slide. Do you have any comments? Maybe co-production. I forgot about co-production to put it in this slide.
Let's see. I've not
Co-production and PROM, yeah.
Yeah.
right. I haven't seen this before, so this is new to
Yeah,
me.
Dr. Nico write it down for
Right.
himself to
Very
teach.
nice. Right.
From Baker and IAPO International Alliance of Patients Organization,
Right.
and then IOM, Institute of Medicine,
Right.
Crossing the Quality Chasm,
Right.
and WHO Quality Dimension, etc.
Right.
WHO Regional Office and Europe, and up to ISQA white paper in 2022.
Wonderful. Wonderful.
Okay.
This looks very good.
Sorry. Yeah.
Very
sorry.
nice.
Yeah. Okay.
Good to see
Yeah,
this.
thank you.
I haven't seen this before. It looks very good. I was part of Box 4, Crossing the Quality Chasm. I was on that
Okay.
IOM task force.
Yes.
And some of this I am familiar with, and much of it I'm not. So thank you for showing me this. Very nice.
I can
Maybe
send it to
Dr. Johnny, Dr. Nico will send it to you
Okay.
Wonderful. Thank you.
in English. Yes, thank you.
Very impressive. Very helpful.
Thank you.
Silakan yang masih ada yang mau bertanya, teman-teman sekali luar biasa yang bisa disampaikan. Professor Eugene, in front of everybody, I want to ask you one more. We have a national meeting on August 6-7 August, and we want you to speak in Dr. Nico's class about patient safety and patient-centered care. Maybe you are the opening. You can show us what's it's like in the world, in the modern countries, in the foreign countries, how the patient safety progress. I will send you the exact because you are the best teacher to us. Thank you very much for your help. Maybe God will always give you health and happiness for sharing the knowledge. In our country, as a Muslim, they said, if you don't share your knowledge, then you have nothing at the end of the world. Okay, Pak Sutoto, mungkin we are spread just like in the United States. So we are in the western part of Indonesia, and on the eastern part, it's 2 hours different, just like you, in the East Coast and the West Coast. So it's already very late at the East Coast. Yeah. Please,
well, time for
Dr.
people to.
Yes.
Yes.
Yes. Yeah.
Okay, Dr. Hani, thank you. On behalf of Kash and all participants, I would like to extend our deepest gratitude and appreciation to Prof. Eugene for the remarkable and inspiring presentation. And your insightful lecture has not only enlightened us, but also the participants from across Indonesia who joined the webinar. Our participant tonight, more than 200 from all over Indonesia. Professor Eugene, the way you emphasize the importance of integrating patient voice and patient-reported outcome measure into healthcare practices to enhance patient experience and outcome was truly inspiring. Your presentation has sparked a valuable conversation among us, encouraging a deeper commitment to patient-centered care in our practices. We are sincerely hopeful that this will not be the last time we have the privilege of learning from you. Your contribution are immensely beneficial and have left a lasting impact on all of us here in Indonesia. We eagerly look forward to the opportunity of welcoming you again in the the future, to share more of your invaluable insight and experiences. Once again, thank you for Prof. Eugene for your understanding and contribution to our webinar. Your dedication to improving healthcare through patient engagement and evidence-based practice is truly commendable and serve as a beacon of inspiration for us. By saying thank God, Alhamdulillah, I close tonight's webinar. Thank you once again, Prof.
Thank
Eugene,
you.
and all participants from all over Indonesia. Thank
Thank
you.
you. Please give a big applause for Prof. Eugene.
Thank you for the very
Yeah.
kind words and the invitation. It was really wonderful to be here with you. I wish you the best of luck, and I know you will do great work in the future as you have in the past. Thank you.
Thank you. Thank you, Prof. Now, Dr. Johnny, please have a closing prayer.
Terima kasih Dr. Hani. Teman-teman, seperti biasa kita akan tutup pertemuan kita lebih afdol dengan bersama-sama berdoa agar hal-hal yang kita dapat pada pertemuan malam ini bermanfaat buat kita dan bisa kita sharing dengan rumah sakit di seluruh Indonesia. Saya pimpin dengan cara Islam. Mohon teman-teman yang bukan Islam boleh menyesuaikan. Bismillahirrahmanirrahim. Alhamdulillahirabbil alamin. Hamdan na'imin, hamdan syakirin, hamdan yu'afi ni'amahu wa yukafi mazidah. Ya Rabbana lakal hamdu kama yabghi wajhal karim azim sultanik. Allahumma sholli ala Sayyidina Muhammad wa ala ali Sayyidina Muhammad. Ya Allah, ya Tuhan kami, puji syukur kami haturkan kehadirat-Mu karena kami telah menyelesaikan knowledge sharing course pada malam ini dengan pembicara yang sangat memuaskan, Profesor Eugene dari USA. Untuk itu ya Allah, kami mohon Kau berikan kesempatan kepada kami untuk dapat menerapkan apa-apa ilmu yang telah kami dapat ini. Mudah-mudahan akan selalu meningkatkan mutu pelayanan kami di rumah sakit kepada masyarakat Indonesia. Sekali lagi ya Allah, kami mohon perlindungan-Mu agar kami diberi kesehatan, diberi kekuatan mengerjakan hal yang Engkau ridhoi dan menjauhi hal yang tidak Kau ridhoi. Subhana rabbika rabbil izzati amma yasifun wa salamun alal mursalin walhamdulillahi rabbil alamin.
Amin, amin, ya rabbal alamin. Tolong dibuka semua supaya semua bisa lihat, bisa menyapa Prof. Eugene. Prof. Eugene, this is our colleagues from hospitals all over the Indonesia, and maybe who's going to say hi, hello to Prof. Eugene? It's okay.